Hi friends, this video we are going to see about the shoulder presentation. Shoulder presentation means it's a transverse lie in which the long axis of the fetus is perpendicular to the long axis of the mother. In the previous presentations, we have seen that usually the lie will be longitudinal. That is, the lie means it's a relationship between the long axis of the fetus to that of mother. Here, the long axis of the baby will be just perpendicular, that is 90-degree angle to the long axis of the mother. That lie is known as a transverse lie. And shoulder of the baby will be coming to the lower segment of the uterus. In the transverse lie, the shoulder of the baby will be coming to the lower segment of the uterus. See here, the shoulder is coming to the lower segment of the uterus. You can see over there. Next, we can see the different positions in the shoulder presentation. In the case of shoulder presentation, the denominator is acromion process of the shoulder. So, if the denominator is pointing towards the left iliopectineal eminence, that position is left acromio-anterior. If the shoulder is pointing, that is, if the acromion process is pointing towards the right iliopectineal eminence, that position is right acromio-anterior. If the acromion process is pointing towards the right sacroiliac joint, that position is right acromio-posterior. And if the acromion process is pointing towards the left sacroiliac joint, that position is left acromio-posterior. These are the common positions in the case of shoulder presentation. Now let us see the causes of shoulder presentation. These causes can be divided into maternal causes and fetal causes. First, let us see the maternal causes. Lax abdominal and uterine muscles. Because of the laxity of the muscles, the baby may occupy any space in the uterine cavity. So this lax abdominal and uterine muscles commonly you can see in the case of grand multipara. Next one is bicornuate uterus or septate uterus. If septa is there or if two cornuates are there for the uterus, the upper segment will be, the size of the upper segment will be less. So the baby will naturally occupy the more spacious lower segment of the uterus. And next one is contracted pelvis. In the contracted pelvis, in the case of normal cephalic presentation, if the pelvis is spacious, what will happen means near to the time of labor, the presenting part, that is the head, will start to enter into the pelvis. But here, if the contracted pelvis is there, space won't be there for the head to enter, so the baby may go back to a comfortable transverse position. Next one is polyhydramnios. In the case of polyhydramnios also, the space inside the abdominal cavity is the reason, and usually there is delay in the engagement also will be there, and because of these reasons the baby may occupy the widest diameter. And next one is placenta previa. If the placenta is located in the lower segment of the uterus, in that case also when the head is coming downward, this placenta may prevent the head to enter into the pelvic cavity and it may go to a comfortable position. Now let us see the fetal causes. The fetal causes include preterm baby and macerated baby or dead fetus inside the uterus. In these two cases, the capacity of the muscles will be less, or the muscles of the baby will become flaccid and attitude will be deflection, so the baby may occupy any of the space. Next, let us see how to diagnose this shoulder presentation. In the abdominal examination, usually in the normal presentation, if it is cephalic presentation, the head will be, you will be able to feel the head in the lower segment of the uterus. But here, the head you can feel in any one of the iliac fossa or in the flank region of the uterus. Either in the flank region of the uterus, here in the flank region of the uterus or towards the iliac fossa. You can see there. And the breech also will be in the opposite side. If one side flank is head is there, means the breech will be on the opposite side. And if you are palpating the fundal region, usually the fundal region will be empty and the size of the uterus will be lesser than that of gestational age. Most probably the uterus will be having size up to the at or just above the level of the umbilicus. Only that much size will be there for the uterus. And fetal heart sounds will be heard below the level of the umbilicus. And if you are doing the vaginal examination, in the early labor, the cervix will be elevated and the lower uterine segment will be imperfectly filled because the shoulder is not a well-fitted presenting part, so that portion will be empty. And in later labor, the cervix is sufficiently, even if the cervix is dilated also, if the cervix is dilated, we can feel the scapula. See, usually in the case of cephalic presentation, you will be feeling head, occiput, all those things. But here you will feel the scapula, acromion process, clavicle, axilla or ribs of the baby. And for confirming the position, if the arm is prolapsed, sometimes in the shoulder presentation, the hand may come out of the uterus. See here the hand is coming out. If the arm is prolapsed and supinated, the dorsum points to the back and the thumbs points to the head. By this also you can confirm the diagnosis of shoulder presentation. Next, we can see the management of shoulder presentation. During the pregnancy, you can try for external cephalic version. And even at full term also you can try for the cephalic version. Even if early in labor, if the membranes are before the rupture of the membranes, you can try for the version. And if abdominal muscles are lax or if uterine muscles are weak, the version will be easier for you. And the fetus will be rotated only in 90-degree angle. So it will be easy for you to do the version when comparing the breech presentation. And if the external cephalic version fails, you can go for the external podalic version. And during labor also, if the membranes are intact, you can try for the external cephalic version. If it is success, immediately you can go for the rupture of the membrane and you can apply an abdominal binder in order to prevent the baby from going back. And if the version fails, you can try for the cesarean section. That is safe for the mother and for the baby. And if the membranes are ruptured before the full dilatation of the cervix, in that case also, it is better for you to go for the cesarean section. Next, management. Nowadays, if transverse lie is there, usually we will be going for the cesarean section if the fetus is alive. Here they are telling that if it is died also we will go for, but if the fetus is alive we can go for the cesarean section, otherwise you can go for the destructive operations for extracting the baby out. Next we can see the complications of shoulder presentation. There is a chance for cord prolapse. Already I have told you that the shoulder is not a well-fitted presenting part. So through the sides of the presenting part, the umbilical cord may escape. And there is a chance for impacted shoulder. The shoulder will get engaged and there is a chance for improper rotation of the cervix and it may get impacted over there. And that may leads to obstructed labor. And if obstructed labor is there and if it is not diagnosed and again if the uterus is contracting, there is a chance for rupture of the uterus. And finally there is a chance for fetal death. If rupture is there, if neglected obstructed labor is there, in that case slowly fetal distress and fetal death will occur. Thank you for watching this video. That's all about the shoulder presentation.